Okay, so thanks for the introduction, and especially thanks everyone to attending this webinar. And this is very informal presentation. So my main purpose is try to raise the interest of people, to working on this kind of topic. It's quite challenging, and also, it's everyone got their own method, and it's very difficult to compare different, between different methods. And also the results we always got, it's some kind of, sometimes the same trend, sometimes a different trend. I think that's quite normal because this is the field, started within 10 years. And so, that's quite challenging, quite interesting, but also, there are a lot of confusing stuff over there. So in this talk, I will focus, first is what kind of role of BBB in a lot of neuropsychiatry and also neurology disease, and what kind of dysfunctions they normally have. And then the main focus will be review the existing approaches to mapping the BBB permeability. So here the mapping, one is going to have a spatial resolution, but they also can have global BBB permeability. That's also very important. And the main part will be focused on the approach I have designed, ideals, the intrinsic diffusivity encoding of arterial spin labelings, arterial labeled spins, okay? Yeah, and then, we are talking about the clinical applications of BBB water permeabilities, and using our approach and also using the approach from our colleagues. And we'll raise questions about what kind of the challenge it is, and especially how to interpret the result. And then when you conclude this talk. And we know that the BBB is a highly specialized and a selective interface separating the blood from the extracellular fluid. And they have these tight junctions and astrocytes and all these very complex things. And there is a difference between health and disease. And the certain molecules able to enter the brain parenchyma through BBB. And this BBB, so BBB itself is very crucial in maintaining the brain hemostasis and this normal brain function. And we know that, wait a minute. Yeah, so there's one big part of BBB, disruption is we are looking for the tight junctions. And this tight junction is a larger, multiple protein complex that will be stick these two, two cells. And this kind of transmembrane proteins we know in this tight junction, and they have claudins, occludins, and all these kind of molecule is we know they are different when the like in the disease state, like in the multiple sclerosis, and this is a normal appearing white matter, and but in the lesions, and there's big disruptions of the localization, dislocation of this kind of transmembrane proteins in tight junction, and also they can even loss of certain molecules. And that's people normally do in histology to verify, the disruption of BBB in certain disease. And sorry, why is it not show up? Okay, so we know that BBB is play a big part in a lot of psychiatric disorders, and yeah, I don't know why this does not show up. Okay, so there has alternations of in the psychiatric disorder, the disruption of BBB normally is very subtle, and they initially start with the alternations of tight junction proteins. And this lead to increase the paracellular extravasation of the blood constituents, and which will induce neural inflammations and leading to a cascade of all these effects. And eventually we'll have the microglia activations, and also this neurovascular unit, this dysfunction. Okay, so this is one examples, okay, in the autism spectrum disorder, and this is on the postmodern studies, and the people did find out they have alternate expressions of genes associated with these tight junctions, and they also detected the increase of neuroinflammation markers and increase microglia activations. And in very interestingly, they also found out that in the gut barrier integrity is also impaired in this kind of disease. So maybe thinking the gut and the brain, they are maybe linked, to this a lot of psychiatric disease, including this autism spectrum disorder. And for these BBBs, we already see the main purpose is try to separate this blood constitute and the brain parenchyma. And for the BBBs, they are definitely had to be permeable because all the nutrients and the water and all the other things had to be crossed from blood into the parenchyma, and also the metabolic waste had to be carried away from by blood. So there's multiple pathways to crossing this blood-brain barrier, including these paracellular pathways and a lot of water-soluble contents you're able to freely passing through. And they also have a transcellular approach, like the lipophilic compound able to directly cross the cell membrane and go to the brain parenchyma. And there are also other transporter, facilitated, exchange, like for the glucose, amino acid, and all these. So there's a lot of mechanisms. So it's basically see this kind of transporting across BBB is very complicated, and that's maybe the reason why it's quite difficult to. We always got some kind of conflict result, when we compare to different disease. And how mapping the blood-brain barrier permeability. And for conventional ways, one is just using some kind of agent, like PET compound, and they are able to directly measure the permeability surface area product of the BBB. But this kind of PET compound always we have associated with high cost, and some of it, maybe need on-site cyclotron. So it's not so many institutions able to afford that. And they're also able to using the CT contrast, and that's very straightforward. And also it's quite cheap to do that. And we are able to directly see, how much CT contrast able to passing through the disrupted BBB. And but this is very efficient. But we have a high risk associated with ionization of CT, and also the leakage of the contrast itself, or CT contrast itself. Some people is in high risk of that. And the third type approach is using the MRI. MRI compared to CT is relative safe, and we are able to using the MRI contrast, gadolinium-based contrast, and to quantify the K-trans. Basically, is the flow rate of this transporting of this gadolinium compound into the tissue. And but these things works for certain diseases like tumors, and we already know there's a breakdown of the capillary walls. But in other neurological and psychiatric disease, and this kind of breakdown normally is very subtle. So using this type of approach, DCE-based approach, is directly to visualize or access the transporting of the contrast across BBB is always have low sensitivity. And the risk of get contrast, for this kind of application normally is small, but maybe still, we cannot ignore if we try to monitor, the certain kind of disease progression. And this is some studies did on the early AD patient, and we can see that with increase, compared to this healthy control, this is age 80. And we can see there's small amount of gadolinium, they can leak out. They can leak out. The brain is not, the BBB is not tight anymore at a very old age. And but in this 80 patient, 60 years old 80 patient, we can see more leakage. So it's more leakage. So this kind of global and also regional BBB leakage and maybe is a part of cascade of this kind of pathological event, maybe eventually leading to the decline of cognitive functions. But we can see that the lesion is, this leakage is very small, and it's very highly difficult to, quantify that. And with the improvement of technique, and people are able to do, use GAD, and just increase the acquisition times and also optimize other parameters. And people are able to raise the sensitivity of this GAD permeability quantification, DCE GAD permeability quantification. So this is the one study did by the mental group. And they are able to see that, in the this older patient, and they can measure the permeabilities of K-trans for gadolinium, and they found out, and with increase of age, and in the hippocampus area, especially the one sublesion of this hippocampus, and the gadolinium K-trans is highly correlated, positive correlated with the age. And so, this basic thinking is this kind of hippocampus breakdown, BBB breakdown, maybe this starting point leading to the cognitive impairment. And also, this thing can also work on the multiple sclerosis. And based on their findings, and in the multiple sclerosis patient, and compared to healthy control, and they have globally, they have large increase of the gadolinium permeability, and in the normal appearing white matter, and also for the whole brain. So with this kind of gadolinium contrast, and we are able to measure large breakdowns, of the BBB, and we already say, the sensitivity is always the issue. So how about we using the water? And because the water molecule has much smaller size, and they suppose should be more sensitive to the subtle BBB breakdown. That's because, for the water transporting across BBB, they have a lot of pathways, and mainly two categories. One is passive, and they can either go for the hydrostatic pressure, because pressure inside the vascular capillaries is higher than the surrounding tissues. And also, they can using aquaporin. Aquaporin is, even though it's transporter, but is a passive passing flow. And they also have active water transporting occurs over there. For example, for all these sodium, potassium, and glucose, glutamate, when they cross these cells, and they will co-transporting the water. For example, in this sodium, potassium, and chlorine co-transporter, and for one metal ion go there, and they are able to attach 570 water molecules. So, this may be one major pathways for this water exchange across BBB. And so we can say for both passive and active pathways, and they maybe reflect the structural and functional integrity of the BBB. And how can we measure that? And one way is using oxygen 15 PET, and that's is gold standard. And we can, because they're able to directly measure the permeability surface area product for the water, and also extraction fraction of water. But they always, is high cost, and we have to have on-site cyclotron. So, we have very limited access for that kind of technique. So second type is the user contrast. And the MI contrast, we are measuring, but we are not directly measuring the permeability for the contrast itself. We are measuring permeability for the water and the K-trans for the water. And we can use a steady state approach, to let the contrast inside the capillaries reach to a certain concentration. And this kind of exchange of this intracellular water with extracellular water will affect the T1 or maybe T2 decay. Most likely should be T1 decay of the signal. And we can use steady state, or we can use in first pass. So that's the shuttle speed DCE approach. And this approach they normally have the contrast approach, normally have a higher signal to noise ratio because the difference of the T1, T2 properties caused by this contrast is much higher. The change is high, but they have two major disadvantages. One is contrast leakage. When contrast leaked outside the vasculature, and then all the model will break down. And yes, they still have change over there, but it will be very complicated. Second is the risk associated with the MR contrast. So the approach I will promote, okay, for today is use ASL-based approach, and we are using endogenous water inside the arterial blood, and as a tracer to quantify the BB water permeability. So for that, we are able to measure is the K-trans for the water, or we are able to measure the permeability surface area product for the water, PSW. And there's a lot of approach proposed, and it's basically using the MR property difference between this intracellular and extracellular as the water. And we either can using the T2 based, and we can use TE ASL, or it's more like the T1 based. It's a post-labeling delay, different post-labeling delay, and they can affect the T1 of the apparent T1 of this ASL signal, and or you can use in magnetic transfer because the water inside the blood and the water in the in the tissue, they have different MT properties, and there also has a large difference of the diffusion properties for these two pool of water, and especially the pseudo diffusion effect for the water inside the vasculature, because they have a motion and a random motion, the random blood flow. And there's several types of this kind of approach. Is the diffusion weighted SL, initially proposed by JJ1 group, and now they improve that to incorporate the 3D. So is the diffusion prepared the Picasso, and also the approach ideals approach I proposed. And we are always using the pseudo diffusion properties because the difference between this intracellular water and extracellular water pseudo diffusivity is more than 100-fold difference. And we are also able to using SL to measure the whole brain water permeability. And this the Dr. Lu's group, and is a webcast, and it's very interesting and highly promising. And for all this ASL-based approach, and people always say is the SL signal already has low SNR, and now you have to quantify, separate into two different components, and this definitely intrinsically will have very low SNR, and also all this kind of exchange either depends on the ASL signal model or by the difference of the diffusivities and all these properties. And they can introduce some kind of sensitivity due to the model, because we have to make a lot of simplifications in order to work. So this is early studies and using the oxygen 15 PET, and basically inject two radio compound. One is this butanol, another is oxygen 15 water, and the butanol, and they are able to freely passing through the capillaries. And for the water, we see the extraction fraction of water is not 100%. Okay, it's also decrease over increase of the blood perfusion, and that's supposed to be normal. Meaning this capillary walls, is permeability, is not infinite. And with that, and they are able to measure the PSW and also EWE in the human. And this is a nice figure, and basically says that how they correlated with the CBF. And we can see that with increase of CBF, and then the permeability surface area, the PSW increase. This is on the healthy subject, and also this water extraction flashing decrease. And this is the result. I will compare that during the talk. And also, this is a full brain approach with webcast and they are able to measure the permeability surface area product, and we have the label this ACL water, and then separated with the phase contrast, and eventually they can estimate the whole brain water permeability. And this is the shuttle speed DCE approach, and they have mainly is Lumi, their group, and they did a lot of research in this area. And this is they can see that the contrast in the plasma, and they will affect the decay of the whole tissue, because the active exchange across the BBB, and also the water across from interstitial space to this neuronal space, and they are able to model that during the first pass of the contrast agent, and able to measure the KPO, basically the exchange rate, equilibrium exchange rate from this blood into the interstitial place. And the limit of that approach is the spatial coverage, because in order to do that, they have to quantify the T1 changes across this profile, across this time course, first pass. So currently they're only able to do single slice. And using SL, we are using the endogenous water, it's a plasma water as a chaser, and when it passing through from artery into capillaries, and they will actively exchange out into the extracellular space, and the leftover is the residual, will be eventually outflow from the veins. So we are trying to model the effect of this exchange into the SL signal, and hopefully from that, we are able to measure the exchange rate. And so the important thing is how can we separate this intra and extravascular signal? And if we are able to separate that, then we are able to have direct quantifications of water extraction flashing, and also the water permeability. So this is one study, directly, model this as a signal by incorporating the exchange between intracellular and extracellular space. And if we change this post-labeling delay, like this is a PESO, so with the TI, okay? And for each voxel in the SL signal, we are able to model that. And from that, we get parameters about the permeability surface area product, and also the blood volume and all this. And blood volume is quantified separately, okay, using CSF suppressed IVIM. The other way, they're able to get the total blood volume, and not exactly the capillary blood volume, but the total blood volume. And from this extraction flashing and that, and then can go to this permeability surface area product. And we also able to using the relaxation difference directly quantify the two set of the water pores, and we can using the MT or use the T2, like this is the T2, based on the T2 of the SL signal at a different TEs. Okay, so we can have T2 map, and from that T2 we can quantify how much water is inside, how much water is outside, and also we can T2 star, or maybe even use T1 low. And this is quite another quite interesting applications, and using the T1 low difference between this water inside the capillaries and the water outside. And here, we can able to study the kidney, basically the kidney function for this arterial spin labeling water. They can either go filtered out through the glomeruli or this kidney and enter these tubules, and or they can exchange out into the renal parenchyma. And using a T1 difference, we are able to measure the single kidney filtration rate. And the difference of this T1, T2 between this SL water inside the capillaries and in the parenchyma always is very small. So, how about we can using diffusion, because the difference between self-diffusion and pseudo-diffusion can be quite big. So this is the initially study initially proposed by J.J. Wang, and more than 10 years ago. Okay, and they do is apply different diffusion gradient, and for the SL signal we can see that is the looks like have two decay component. We can fit this with two component decay, and for the reference tissue signal, and is more or less a single exponential decay, and there are small fractions. Okay, fast one corresponding to the flowing blood inside the brains. And if we separate that, and we can quantify how much fraction of water is in the capillaries and how much fraction of water is exchanged out into the brain cells. And more recently, they are using that approach to study the OSA, the obstructive sleep apnea. And we can see that the K-trans for the water is different, is lower in the patient versus in the healthy control. And for this, it's the original DWSL is a 2D acquisition. And so they cannot have full brain coverage and have limited coverage. And also for 2D acquisition, it's very difficult to implement the background suppression, so they are more sensitive to the physiological motions. And more recently, they improve that technique to create a diffusion prepared Picasso with 3D grace acquisitions, and they are able to check the diffusion, the weighted signal at different post-labeling delays, and they're basically using two-stage approach. One is using very small b values, like the 50, and this will able to kill very efficiently kill the blood signal in the precapillary arteries and arterioles, and also compare this one with the p equals 0, and so two-stage. Okay, p equals 50 and p equals larger values, and from that, so they are able to measure the K trans for the water, and with this approach they have improved spatial coverage. And but the issue is when they do the diffusion preparations and using stimuli echo-based diffusion preparation, and this will automatically cut half of the SL signal, and also this diffusion preparation block and the signal they have T2 decay. So the signal will be a little bit smaller, but the result is very impressive. And I developed a new approach because based on the intrinsic diffusivity of the 3D grace cells. So we do not add a separate diffusion preparation block. And the inspiration for this technique is coming from one of our early studies. And at that time, we are using 3D grace for the acquisition and Picasso 3D grace, and we found out the quantified the apparent SL perfusion CBF is depends on the segmentation factor we are using. And with high segmentation factor, and our apparent perfusion value looks like it's higher. And in this particular study, we are using the post-labeling delay of 1.6 seconds. And we can see that they almost have about 20% signal, apparent CBF difference acquired at different segmentation factor. So this is another example is we compare 2D acquisition, and which do not have this segmentation related artifacts, and versus this 3D one. And this is we have 4 segmentation factor of 4 in the partition deletion and factor 2 on the face encoding deletion. And we can see even with that, we are still, our apparent CBF is still will be lower. So basically this kind of perfusion CBF quantification bias, and it is sensitive to the segmentation factors. And sure, this there's some kind of true tissue diffusion occurs, and also the T1, T2 relaxations of the signal cells. But that only account about 65% of the CBF estimation bias. And so what can be the reason? And we're thinking is that because when we do 3D grace acquisitions and we acquire different case-based lines along this echo chain, and this one, if we model that signal, and we can see that with the increase of echo chain number, our signal will decrease. And normally we using the this at each block, we acquire different partition KZ values. And so that kind of things will lead into after Fourier transformation. Basically, we lead into a kind of blurring effect, blurring kernel along the phase encoding direction. So this is the leveling signal. We can see that when we use 3D grace with very low segmenting factors, and that will be our signal looks like, image looks like. And there's a lot of blurrings across the partition directions. And that's, if we increase our segmentation factor, and then this blurring is much smaller. And if we look at the point spread function, we can also see when the partition direction segment factor 1 and is more broad, and the partition direction factor of 4, segment factor 4, and is much more sharper. So the reason is that are we able to use this to really get what we want? So we always say that these kind of things leading to the CBF estimation bias, and the certain part like T1, T2 decay, and also the self-diffusion, and it can be modeled with the extended phase graph, and very straightforward. But for this ASA water inside capillaries, and they underflow the pseudo diffusion, and we designed another approach we call augmented extended phase graph to model that, and combine these two signals, and then we are able to really get the reasons for this CBF estimation bias. And from, I think we'll do not have too much time to talking about this part. It's an extended phase graph, and basically is this when the water across this cholesterol gradient pair, and they will have some kind of phase encoded, because they can go to Z direction, stored in Z direction, and that Z direction is the phase encoded. And when we imaging and we try to bring back to the horizontal, transverse direction, and also try to negate this kind of spatial encodings, and we can represent that using the kind of extended phase graph, and we can use that to represent the effect of the alpha pulse, the gradient, T1, T2 relaxation, and also the bulk motions, and also the true diffusions. And for the augmented extended phase graph, we are dealing with this random flows inside of the capillaries. And when they cross different gradient, cholesterol gradient, and they will accumulate phase. And this phase, suppose we know certain directions, okay? Given direction, this phase will be proportional to the gradient moment it experiences along this trajectory. So therefore, for each state, and we have to remember its history, which gradient it passing through, and how much gradient moment and it is able to accumulate. So we separate that too, and with that, we are able to quantify how much attenuations will occur for this intracellular water due to this pseudo diffusion effect. So with that, yes, it introduced the CBF estimation bias, but we can also use that effect, to quantify, or we can separate this intracellular versus extracellular contributions. And we call this approach called ideals, intrinsic diffusivity encoding of arterial labeled spins. And basically for the extracellular water, and also intracellular water, we acquire two different segmenting factors. At a high segmenting factor, and this point spread function is quite sharp, even for extracellular water, still reasonable, okay? But when our segmentation factor is very low, and basically more like a single shot acquisition, and then for both extracellular water and intracellular water, and there's large spread. and the spread difference, point function difference. And this will allow us to robustly separate these two pools of water. And the separation of that is able to really quantify this water extraction flashing and also this PSW. And this is really our signal model. And but we know always SL signal have low SNR, so we normally are not able to fitting across a single lines. So we're using a 3D partial volume collection to combine the lines at the neighborhood and fit simultaneously. Underlying assumption is that for the pixels very close, and the gray matter signal and the white matter SL signal is more like similar. Okay, so that's the underlying for the partial volume collection. So from that, we are able to separate how much flexions inside capillaries, how much flexions is go to the parenchyma, and from that, even at the end, we are able to combine it with the CBF measurement. If our post-labeling delay is long enough, so assuming that all the exchange has been completed, and then we are able to measure the PSW for the water. So this is really, slide shows how we do this kind of deconvolution. And we already know that deconvolution always not stable. So we, always choose voxels, not voxels, the lines, at the neighbors, like in this voxel, line we pick up, we always pick up 4 lines at the close nearby. And we plot out the signal along this slice direction. So total we have 5 lines. And we assuming is that, they each have gray matter and white matter. And gray matter have white matter have different water extraction flexions. But, the pure gray matter and pure white matter, they should have the same amount of the perfusion signal. And basically partial volume, collections. And from that, when we do the fitting, okay, and we can got the extraction flexions from this, and so this is not the method itself is still have a lot of room to improve because we are dealing with a very low SNR for the perfusion signal. And so this is the result we got. So this we combined more than 10 healthy subjects and overlap each other, align each other, and then overlap each other. And this is the PSW map we got. And we can see that gray matter lesions has a higher water permeability than the white matter lesions. And also, the water extraction flashing in the white matter is a little bit higher than in the gray matter lesions. And you can see that's quite interesting. And because our approach is able to provide the full brain coverage and not the voxel wise, because we always do the smoothing, because when we do fitting, we are using every 5 lines simultaneously, okay? So, we do not have very high spatial resolution, but we are able to enable us to do the ROI analysis. And so some people will question is, maybe the post-labeling delay you are using does not allow for the completions of water exchange. So we just very different post-labeling delays compared to 1 second, 1.5 seconds, 2 seconds, and 2.5 seconds. So you can see that when we are post-labeling delays between 2 to 2.5 seconds, and there's very little difference for the estimated water extraction flashing, and also for the estimated PS value for the water. So at least in the healthy subject, so I think is using a post-labeling delay of 2 seconds is reasonable. But for the patient, with much reduced CBF, then I believe our post-labeling delay had to be increased. And this ideal approach is able to provide the regional difference of the water permeability. So we compare the cortical gray matter, deep gray matter, and subcortical white matter, and the deep white matter. And we can see that the cortical gray matter, the high water permeability, and this deep gray matter has a little bit lower. And also, this deep gray matter really is very close to the critical white matter permeability, but the smallest permeability occurs as deep white matter. And basically with decrease of the CBF in these 4 regions, and we can see that water extraction flashing is increased progressively. And they also have some kind of gender difference compared to male and female. We can see that the female, this is more or less young and middle-aged subjects, and the female has high blood perfusions, and we observe that in all regions, and the female has lower water extraction flashing compared to the age-matched male. But if we look at the PS value for the water, really they have very little difference between male and female. And we also plot out, the correlations between these water permeability parameters with the CBF. We can see that in healthy subject and at different regions, and this is not each point is not a single subject. It's really is a single ROI, ROI. So even though we did 10 or 15 subjects, so we have a lot of points, we got a lot of different blue regions, and we can see that with increase of blood flow, and this water permeability increase, and also this water extraction flashing decrease. So this is very close to what observed from the PET studies. And we also did some kind of caffeine challenge, and we can see with the caffeine challenge and the CBF decreased significantly, but and also this water permeability PS also decreased significantly, and accompanied with the decrease of this water extraction flashing. So that meaning, this ideal approach is sensitive to this water permeability measurement. And we also did some kind of visual stimulation, and we presented it at the ISMIM. And but that's not that kind of interesting. Okay, with during visual stimulation, you can see the blood flow increase significantly, but the water extraction flashing looks like they have a very little change. So, but because blood flow increased significantly, so we also see that there's a large changes increase of the water permeability during this visual stimulation. And we also use this approach to study the multiple sclerosis patient and the RRMS patient, and is a middle-aged one. And we compare that with healthy control. So this is the combined result. You can see that compared to healthy subject and the MS patient, the globally they have reduced CBF and also reduced the water permeability. But this water extraction flashing looks like the change is very subtle. You're not able to see very, the difference. If they have difference is quite small. And we separate into different lesions, like lesions and lesion area and normal appearing white matter. And we are able to see that, in normal appearing gray matter and normal appearing white matter, and there has a large difference, significant difference of the water permeability, and this is edge collected, okay. And also the reduction of the water extraction flashing in this MS patient. And in the lesion, compare lesion with the parallel lesion area and also normal appearing white matter area, we can see a lesion has a lower perfusions and have a lower water extraction flashing. But this, lower PS for the water and a little bit higher, but compared to normal appearing white matter, they still reach some kind of significance. A little bit higher water extraction flashing in the MS lesion. And now we focus on the clinical applications of the BB water permeability, not only for our ideal approach, but also the other ASL and other contrast-based MR approach to see, we can find out is there's a lot of people come up and they provide a highly promising approach. But the difficulty is that a lot of this kind of result, including ours, and we do not have direct validation. if we want to validate, we have to use in the oxygen 15 to do that. And the most confusing part is, we do not have very consensus, about what will be changed about the water permeability, in disease state. And the report, the result reported is some kind of conflicting each other. So we have no idea how really would happen. So for example, so this is the using the DWSL and looking for the sleep apnea. And remember, I emphasize the age of this patient. Okay, so this age is this patient is 47 years old, and we already see that using 2D SL, so they only do the silver slice. And this found out there's no significant change on the ATT. But there's a significant reduction of the K transfer the water in the OSA patient, not only for the global gray matter, white matter, but also for the the certain specific regions. And this kind of things is more consistent with this mitochondrial hypoxia and mitochondrial dysfunctions in the obstructive sleep apnea. So on this study, they observed the reductions of the BBB water exchange. And this is another study we did. It's a pilot study, okay? So we only did 4 subjects, and 2 male and a female, and this OSA patient, and we undergo through the 6 weeks of CPAP treatment, and we try to see what kind of changes, this CPAP treatment, and we see that after the CPAP treatment, there's an increase of blood flow, and water exchange fraction may be very little change, but also we saw the increase of PS for the water. And we see that the CPAP treatment increase both global gray matter, water permeability, but also see some kind of regional water permeability improvement in the amygdala, hippocampus, and also some other regions. And because we only have 4 subjects, okay, so we do not do any statistical analysis. We are only looking for the trend. So our trend is that the regional increase for the water permeability and the CBF is not a lot of different area, okay? And so at least we see, we tend to conclude that this kind of CPAP treatment is able to improve the BBB integrity because they increase this water permeability. And this another study we presented at the ISNA, and this is in the people with the major depressive disorder, and we have 14 patients, and also middle age is 49, and we are using IDEAS, same thing. We are using IDEAS approach, and we found out the significant reduction for both the water extraction flashing and the water permeability in the global gray matter and white matter, and also in the region known to be affected by this depletion. And for this water exchange flashing, EW, we saw that there's a significant reduction in most of the regions like amygdala and the hippocampus. And if we compare the CBF, and a lot of area we do not reach the significance, statistical significance. So this is another study did by JJ's group, and they try to compare the water permeability and with this gadolinium permeability in very old subject. Average age is 68, and they are using the diffusion prepared Picasso, and also use DCE to get the K trans for the gadolinium. And they found out this there's some kind of correlations of these 2 parameters in the white matter region, which is significance, and also in the MCA reflector territories, they reach significance, but a lot of areas that do not reach significance. And also they found out is in this area, with increase of gadolinium permeability, and this Kw for the water also increase. So meaning have more BBB damage, and there's higher water permeability. That's the findings. And also the same group, and they compare this, how they correlate with this water permeability with this CSF amyloid beta compound concentration. And they found out with the increase of this CSF amyloid concentrations, and they saw the increase of the Kw, increase of Kw. So Kw is positively correlates with this CSF amyloid concentration. And this amyloid CSF amyloid concentration is some kind of marker also for the BBB integrity. So basically from these studies, they see this with more discussion of the BBB, and they have a higher Kw for the water. And this is Dr. Park's study. So it's in the AD model, in the ladder model, and they try to using the measure the BBB permeability using multi-flip angle, multi-echo approach, and how they correlate with histology. So they investigated this occluding and other compound. You can see that in the AD mouse, they have the less occluding, meaning there's more tight junction dysfunctions in these AD models. And with this decrease of occlusion, and in a lot of lesions, okay, including this whole brain, okay, and with decrease of occlusion, meaning more AD, more BBB damage, and they observe higher water permeability, PS for the water. And for this AD model, they do not observe any kind of get contrast leakage. So that maybe see that that indicates the structure of the BBB itself is still more or less intact. And this is another study is Dr. Lu's group, and just published recently. And they did this water permeability using the webcast, so it's a whole brain. And in the people with mild cognitive impairment, and also in this age group, is the mean age is 68, so it's very old people. And so compared with the healthy control, age-matched healthy control, they observe globally, okay, the increase of the water permeability, and also this increase of water permeability globally, okay, is associated with the decrease of cognitive function. So that's a very interesting result. But we can see that each studies locally have a different kind of trend. So this study is using the shuttle speed DCE MI, and they measure the BBB water permeability, and they are looking for this progressive multiple sclerosis. And the patient also is a very old age, every mean value is 57 years old, and they did on 70. Okay, so they have huge signal to noise to play with that. And their findings is that in the normal appearing gray matter, and this KPO, that's the equilibrium water exchange rate, and this PS for the water reduce in this patient. And also in the lesions, in the white matter lesions, and the KPO is reduced compared with this normal appearing white matter. So in that study, they saw is a reduced water exchange in this multiple sclerosis patient. And they also did the same group, and they did this aging effect in the water permeability of water, and same kind of result. And they see with advanced age, and this equilibrium water exchange rate reduce progressively. And this is consistent with the progressive reduction of cerebral metabolism with the increase of age. So from this study, we can see that this water exchange is more reflect, this active mechanism for this cerebral metabolism. And this another study is on the lupus patient, and this is a more younger age patient group. Average value is about around 20 years old, and they are using the Ph.D. post-labeling delay SL, and to separate this quantified exchange rate, and also using IVIM for the blood volume estimation. And from that, they are able to calculate what will be PS for the water. And their finding is that they have seen the increased regional BBB water permeability in the lupus patient. And this kind of increase is water permeability is negatively correlated with this kind of, this kind of neurocognitive function. So on this study, they saw increase of water permeability in this specific lupus disease. So we see a lot of studies, and the conclusions always looks like conflict each other. At least we do not have consensus what thing happen. So why is this? I'm thinking is also a lot of authors in their report, and I'm thinking that's really because the multiple pathways of this water across BBB. They can either cross, if the tight junction truly break down, there's big holes over there, definitely water can cross this from the blood into the parenchymal tissues. And also if there is changes occurs in this both passive or passive transporters, co-transport for the water, and then they will also affect this kind of water permeability. And there is a study, okay, looking for the role of aquaporin transporter for the BBB water exchange. And this also using the mouse model, and it compares the normal one, wild type, and this aquaporin 4 deficient mouse, and they're using multi-TESL to quantify the water exchange time. And they found out in this mouse with deficit on the aquaporin, and they have increased the exchange time, meaning they stayed inside the vascular longer. So meaning their water permeability reduced. So this seems that aquaporin may be a very active part for this water exchange business. And we know in a lot of disease, including the psychiatric disease, and there is a dislocations of aquaporins at the surface of the BBB. And also, looking for active pathways. And there's a lot of study from Charlie Springer's group try to quantify how much fractions of water is cycled through active transport mechanism. And their conclusion is that this kind of water exchange is mainly, or at least more than half, about half, is due to this active co-transporting mechanism. So if this brain metabolism is reduced or maybe changed during this kind of process, during the disease process, then this water transporting across BBB will also be affected. And this affection, this pushing may be, a major part from their ex vivo studies. And they say almost half of that, is this due to this active transporting mechanism. For that is that, assessing the water permeability across BBB may be a promising biomarker, for the BBB dysfunction. And BBB dysfunction is known to be highly, potentially, a factor for a lot of neurological and psychological disease. And also, for the both, the K-trans for the water and the PS of water, can be used to access the regional BBB permeability, okay? Either using contrast or non-contrast approach, both have pros and cons. And also the main part says these abnormalities we observe of the BBB water exchange may be the combination effect of the disruptions of the BBB structure integrity and the disruptions of the functional integrity. And when we do this kind of study, we may have to pay attention to different age of the groups, we recruit. And we see that, maybe in a lot of studies, we find out is that this BBB water permeability may be more sensitive in the younger cohort instead of older cohort, because the difference of the BBB water permeability in the younger cohort is larger. And at older age, at more advanced age, that kind of difference may disappear or may get reversed. And for this research, first I should thank my former Ph.D. student, Ken Wagner, and now he's doing postdoc at Columbia University. And I'll thank also collaborators, Dr. Kelly, Dr. Coyle, Dr. DeLorenzo, and also Dr. Xiang He, and at Stony Brook, and also some of the research done on this mild TBI studies is from Shanghai Jiao Tong University and Dr. Tieyao Wang, and currently is working with Dr. Megan Kelly at Northwell and on the lupus patient.